afternoon. I'm Mary Beth Donahue, President and CEO of the Better Medicare Alliance, and I'm so happy to be here with Juliet Choi, President and CEO of the Asian American Pacific Islander Health Forum. And we could not be here with someone who's focused more on health equity and been a leader in this space and ensuring that all of us, and include myself in our work at Better Medicare Alliance, continue to focus on this aspect of the healthcare system and just the need for us to not just bring awareness, but the focus here is action. And anytime that I've been engaging with Juliet, it's all about certain issues and going to that next step of action. So thank you for making us be sure that we're true to the commitment that we have to the issue of health equity.
Thank you, Mary Beth. I do have to share, every time you've reached out and we've shared, oh, let's have a quick conversation, it always turns into a pretty robust discussion. So it's been wonderful engaging with you and BMA.
Oh, well, thank you. What I thought maybe we could first do is, could you just share some background on the organization and also just your priorities, and then we'll, and I know everything that we're focusing on is interwoven into health equity, but just a bit of an introduction to the Health Forum.
Sure. The Health Forum, we're a national health justice advocacy organization, really advocating for the needs and wellness for the Asian American, Native Hawaiian, Pacific Islander communities. We are national with offices and presence here in the DC area as well as San Francisco, and really the voice of our very, very diverse set of communities are represented back to us through our network of local grassroots organizations. Since COVID, not surprisingly, as well as the changing demographics of our communities, our community local network has grown to over 250 grassroots organizations with a reach into 45 states and territories. And what we do day in, day out, I'm just looking around the room. If you think about someone in your family, a loved one, someone in your community, maybe where you work, your place of worship, different folks have access to different information. When you try to navigate, that doctor's appointment or a particular type of care that you're seeking, for some of us, it can be a very easy exercise to navigate, if you will. But if you think about the diversity of our communities and actually the changing demographics of the country, aspects like language, socioeconomic status, immigration status really come into play. And as we share our conversation together today, I will be drawing upon, a lot of the learned lessons from not just COVID, but also the increase in anti-Asian hate and how that's really impacted how our communities are able or challenged in navigating and seeking care.
A lot of what you do is in the advocacy space, and again, we've had conversations on the resource, the Health Forum, and Juliet are to Capitol Hill and the administration. Can you speak to some examples of what you're currently working on with Congress administration and where you've also had some successes?
Sure, absolutely. So we're really proud. Very recently, actually it was in the month of July, there was the bicameral introduction of the Health Equity Accountability Act, or HEA. And that is model legislation that's been in existence for over 20 years. If you're looking for something to read, the bill itself is over 1,500 pages with 10 titles. But what is terrifically wonderful about this model legislation is that it is jointly led across and through the Tri-Caucus. This year, the Congressional Asian Pacific American Caucus has led the charge, and it rotates across the Congressional Hispanic Caucus and the Congressional Black Caucus. Some priority areas in the legislation are your classical drivers on how to improve the healthcare delivery system writ large. So things like workforce diversity, thinking about access to language, delivery of care that is done in a way that's culturally relevant. There are priorities when it comes to mental health and addressing mental health and substance abuse, as well as, very happy to see the growing shared effort around women's health equity and children and families. A big component that's really important, not just to our communities, but I would ask everyone should take the charge. You don't really see these articles on the front page of the New York Times, but really the need for disaggregated data. You really need the disaggregated data to understand what the community needs are. If you don't disaggregate the data, then there are a lot of hidden unmet needs where with targeted resources and a targeted strategy, a lot of these issues are actually very, a lot of these factors are addressable with these targeted resources and strategies. With the administration, we have, Secretary Becerra, or Administrator Brooks LaSure or Dr. Seshamani. When they see me approaching them, they know we're going to talk about language, disaggregated data, and I would also highlight navigators. And then just pulling the thread around learned lessons, especially from COVID. There really are a lot of parallel experiences from some of our experiences where we have traditionally focused on access to Medicaid as well as marketplace enrollment that are actually, a lot of those lessons learned and successes are absolutely relatable when it comes to Medicare Advantage.
If there's anything of the many things that resonate from my conversations with Juliet, it's that if you don't have data, you don't have equity. And there's nothing more true when we're saying that we're raising awareness and health equity, that if we have that gap in data, then we're not really able to address the gaps in care. And I want to sort of cross into just the intersection with Medicare Advantage. And hopefully you're seeing some progress in addressing those data gaps. But just for Medicare Advantage in particular, what would you look to where we, the Medicare Advantage community, and including the plans, like what we need to do to help contribute to addressing that data gap?
Sure. Well, before I jump into that, I wanted to highlight how having the disaggregated data with the targeted strategies and resources can really make a difference. And I had to pull out my notes to make sure I got these numbers right. So if we can take a moment and pull on some lessons learned from the Affordable Care Act, ACA, and marketplace enrollment, and just kind of taking a 10-year comparison. In 2013, the national uninsured rate was about 14.5%. For Asian Americans, the uninsured rate was almost 15% at the time, and for Native Hawaiian Pacific Islanders, which always indexes higher, was close to 18%. 20 years later, in 2023, the national uninsured rate dropped down to just shy of 8%. Asian Americans down to 5.3%. So you're talking about almost a 10-point differential there. And Native Hawaiian Pacific Islanders still benchmarking pretty high at 12%. Just pulling on the disaggregated data and looking at subcategories. Back in 2013, for example, I myself am Korean American. I was astounded to learn the uninsured rate for Korean Americans in between 2010 and 13 was about 25%, meaning 1 in 4. And when folks started looking at that, it was the realization that in the workplace, because a lot of Americans get their health care through employment-based insurance, it's because there's a high population of small business owners that are Korean Americans. So with that kind of disaggregated data, you can do real targeted resource allocation and outreach there was a quick partnership between HHS and the Small Business Administration, for example. And so as a result, over about a 10, 12-year period, I still think the rate is pretty high, but instead of 1 in 4 being uninsured for Korean Americans, it is now 1 in 10. So you're talking about a 15 percentage point differential. And so parlaying that to your question, Mary Beth, with regard to Medicare Advantage and our plans, I would say, especially with the rapid growth of plans, and also thinking about the creativity or flexibility that's available through supplemental benefits and the designing of that, if we could all take a step back and think a little bit differently, rather than the feds driving the compliance requirements, I would absolutely invite plans to think about how can they invest and make a commitment to collecting disaggregated data and making the data very easily available to all stakeholders. Stakeholders represented here at your convening, for example, because when you have that kind of data, whether you're Meals on Wheels in Washington, D.C.
We're looking
right?
at, if
I figured someone from Meals, yes? Hello, okay. Applaud your, okay, wonderful.
Yes.
I'm a former Red Crosser, and so we partnered with Meals on Wheels. My hat's off to you. You all are a wonderful mission. But when you think about disaggregated data, can you imagine if that local agency, that faith-based organization, that local or state government agency, and the plan together, how powerful that would be, where creating these targeted strategies wouldn't seem so overwhelming, but very, very practical and within reach. I would also, and I know we're going to cover a lot of ground here, but I'm a big proponent of private-public partnerships. So how do we make sure we're building a system for disaggregated data? And if you roll it up a little bit more, how can we collectively come together and design a statement of principles and values that we're all willing to commit to ensure that we can leverage the resources across MA plans to really drive at and tackle and strive towards health equity.
And just as you put that forward, and this could be something that we come back to you, Juliet, but do you see that there's any specific interventions that we could use sort of bridging like health equity and social determinants of health?
Oh, absolutely, absolutely. Let's use language as one example. I think pretty much everyone in the room, English is your first language. But we know the literacy rate, we should design information for the general public, some of my expert friends say, at the 5th grade level, plain language. And as I myself am studying, how MA plans actually work, even in English, it is a lot of information to digest. So I would say some interventions, number one, really thinking about their private-public partnerships is really, I want to challenge the plans. How do we create more investments and resources for navigators? Navigator entities exist, especially in the Medicaid and marketplace. If we think about the spectrum of care from birth to senior years, why can't we, why shouldn't we? Let's go ahead and apply these learn lessons, invest in navigator resources. I'd love to see that be part of supplemental plan designing. And language translation. Almost 75% of Asian Americans do not speak English very well. And with the changing demographics of our country, let's think about the Latino population. Let's think about the African immigrant population, even the European immigrant population. So I would say language access combined with navigators. I'm not a researcher, But, okay, someone over there is raising their hand. I'm willing to bet money we could really see some incredible outcomes in about 5 years if we could collectively make that commitment. So those are just a couple of interventions.
All right. I see a challenge there for us to stay in touch
Yeah.
on. So we're approaching open enrollment, and this is where seniors have the opportunity to make their choice in coverage. And when you're talking about language barriers, you just think about that process. And even if there's not a language barrier, it can be overwhelming. And so just as we approach that time of year and that process, what do you see that our MA community could do? And again, this is obviously led by the government, but we make suggestions as part of that process to make that more easily understood and comprehended, both for the senior population, but then those who are helping them make that choice.
Yeah, great question. I mean, I don't have a magical response to this question. I mean, I think it's just brass tacks, common sense. And again, drawing from the Medicaid marketplace space. I have shared this with, the administrator. Wouldn't it be wonderful if we could figure out a way to at least sort of align these enrollment periods across these different plans? Because if you think about the community groups that are going to interface with individuals and families, the burden really falls on a lot of these community organizations. So I would say, number one, outreach and education campaigns, plain language, social media, multilingual. I'm not super great on social media, but we got to do it. I'm finally on Instagram. But definitely enrollment toolkits and social media toolkits so we can blast this out across the country. And again, if you think about whether it's the government or the plans, those just some basic flyers and making a commitment that will get translated into at least 10 languages. It's just a little bit of investment up front that's absolutely going to make such a big difference, throughout the enrollment period. And again, being able to invest in navigators and uplifting them, I think is going to be absolutely critical when we think about a lot of the communities who just, when you think about how do you get access to your information, I've not seen a study yet. So seniors, individuals in their 60s who are thinking about as first-time enrollees, or those that are wishing to switch plans, I'm not quite sure where and how they get their information on a consistent fashion with a voice of trust. So outside of the brokers, outside of the commercial ads. So I do think this element of outreach and education marketplace over the last 10, 12 years has really designed an ecosystem around enrollment. And so I do think that's going to be really, really critical for enrollment period with MA plans.
We had Nancy Lamont, the Chief Advocacy Officer from ARP, here earlier about the importance of caregiving. And again, that was across the board, all populations and not just seniors. But in that area, the issue of just communication came up and education. And it just seems that whenever we're looking at how to better provide access to care and then ultimately also deal with the health equity issues, it does just come down to communication and health literacy and just understanding. And just given the work that you've done in the communities that you serve and both the community organizations you work with, Juliet, are there any great examples, innovative examples that you've seen from other organizations on health literacy that you think can sort of help address this challenge that ultimately can help, bring equity to the delivery of healthcare?
Sure, especially on the outreach and education. Again, it really is including community partners as stakeholders. And designing the educational information in a way that's really palatable and resonates with the community. So again, I'll draw some examples, especially from the Asian American, Native Hawaiian, Pacific Islander communities, and a lot of the exercises we went through, COVID, post-COVID, and now some of our vaccination campaigns. I mean, things as simple as, having the right set of figurines on a flyer. For Pacific Islanders, right? Like the imagery may look very, very different for East Asians, for example. And when we translate our toolkits and educational materials, if we benchmark at a lower level, we usually translate information into 10 to 15 Asian, Native Hawaiian, Pacific Islander languages. For some of our other critical toolkits, we will translate them into 20 to 30 languages. So it is a bit of an investment up front, but it is such a force multiplier once we have that available. We'll translate the materials, leverage a community partner for cultural and language relevancy. And so it sort of goes through a two-step process of translation and review. And because these kinds of educational materials are in such high demand, the Health Forum, we do host these resources through open source so that all community partners can leverage them. And we create them in digital form so that if an individual organization wishes to download it and add their own community logo to add that sort of trusted voice, it's like a real force multiplier. And that is something we've talked to CMS about. So they've, and they do, the administrator, she does listen, especially on some of the Medicaid and marketplace materials, working with the team at CMS. They were willing to create these postcards and make them digitally available so that community partners could download and co-logo with the CMS logo and the community logo. I was really surprised, pleasantly surprised that they said, oh, that's a great idea, let's go ahead and do that. So that would be one basic intervention. And there was, I remember what I was going to highlight. We're starting to get into this a little bit more. We do a community survey of our partners annually. Last year was our third year in a row. I invite you to look up APIAHF and CBO survey. If you just Google it, it'll take you right to our link. But it'll give you a flavor in terms of what the gaps and the needs are from our community lens. And one thing that actually has popped up, and hearing from our communities helps to keep me grounded, is actually this outdated phrase, the digital divide. A lot of individuals, they do get their information from tablets or smartphones. But for a lot of our communities, access to, just a smartphone is actually still very, very challenging. So, these aren't like magical solutions, very practical, I think, initiatives that if we all were more aware and could collectively commit to addressing, we could really make a lot of impact in a very short amount of time.
Well, I see our next panel's here and my time's ticking away. So I know normally we go on in our conversations, but this one's going to have to get cut short. But I do hear you loud and clear when you talk about the investment up front on all these areas that ultimately lead to action in the health equity space. And as we continue to see diverse populations, and specifically Asian American, Pacific Islander, Native Hawaiian populations increasing in the Medicare Advantage space. It's just, calling out for the need to address any gap in that space. So we want to be a part of finding.
Yeah, no, thank you so much. I mean, I think if I could close out with two final ideas, things for folks to think about, especially through the BMA allyship network and through the plans. And a lot of other corporate arenas, it's not uncommon to create a community advisory council. And so if we could think about a way to design something like that at a national level so that we could collectively address some of the systemic issues and solutions. So for example, on my wish list would be, let's have these community advisory councils, have them at the table, and when we think about designing supplemental benefits, and we heard from the community, what do you think would be the 5 most impactful interventions across these different demographics? I bet you we would get some practical solutions very, very quickly. And then the last thing, evaluation and research is always critical. I know Kaiser Family Foundation did a great article last fall. I'd love to see more research, commitment to research and evaluation when it comes to service utilization by race and ethnicity. Again, that disaggregated data. So, Mary Beth, thank you so much for inviting me.
Thank you. I got lots of ideas here, thanks to you.
Yeah,
It never
thank you.
ends. Thanks so much.
Thanks.